Hi, I'm Dr. Val Brule, your narrator and main content creator for these Bedside Pediatric Early Warning System modules, which I'll be calling Bedside PEWS throughout the rest of this presentation. I'm a pediatric intensivist here at HSC Children's Hospital of Winnipeg, and I'm also the medical lead for inpatient quality improvement. I'm the lead for the Bedside PEWS project. The slide for this module were created by myself, with some content from child health nurse educator Alexandra Austria and clinical nurse specialist Holly Beckering, with some additional content from Bedside Clinical Systems, who are the proprietary owners of Bedside PEWS. Welcome to Module 4, Special Circumstances. This module will review common challenges and special circumstances for bedside PEWS and will review how to deal with them. Note, each slide deals with a new topic, with some of them going in sequence. However, there's numerous topics that will be covered throughout this whole presentation. Firstly, as a reminder, Module 1 to 3 dealt with the science supporting bedside PEWS, how bedside PEWS is used in practice, and some scenarios. Throughout this all, we want to emphasize that the bedside PEWS score provides score-matched care recommendations to augment current site policies and to provide customized responses for each patient. The care recommendations are not meant to replace clinical judgment, they are meant to enhance it. Ultimately, all of the other healthcare procedures, guidelines, evidence-based medicine are still used for each patient, and the score just helps us focus on what may be a challenging situation for a patient and understanding if they have increased risk for clinical deterioration. But again, it does not tell you what's wrong with the patient or what needs to be done for the patient. Bedside PEWS scores trends are actually the most valuable element in bedside PEWS. It's similar to any vital sign. Really, you want to know, is the trend worsening or improving? Is this their baseline? Were there interventions that I did that altered what is going on for the patient? It can be really helpful to break down the bedside PEWS into its critical elements and really trend the different vital signs when you're thinking about a patient. It's also helpful to think about any other clinical changes for the patient that may be outside of the critical elements of the score that could be impacting them. For example, a fever can alter all vital signs, even though it's not part of the score for critical elements. It actually could be the thing driving all of their changes. Ultimately, as mentioned in the previous slide, the score doesn't tell you what's happening for the patient, and this is why both clinical judgment and the score go hand in hand. As a pediatric intensivist, I'm always thinking about the trajectory of the patients. Are they improving, worsening, staying the same? What changed or didn't change to get to this point? Bedside PEWS can augment this clinical reasoning, but your own interpretations of the level of concern should not be ignored. If the score is still 0 and you are worried, you can and still should call for another opinion or review with your team. When thinking about the blood pressure subscore, many people also question why the systolic blood pressure is the only part of the blood pressure that is in the bedside PEWS score. This is not to diminish the importance of diastolic blood pressure. It does and still matter and should be taken into consideration for each of your patients. As you may recall, systolic blood pressure measures the pressure of blood pushing against arteries in the active phase of the heartbeat, and diastolic blood pressure is the same pressure in the system, but when the heart is filling between beats. Therefore, diastolic phase is passive and systolic is active. The diastolic blood pressure is considered clinically important in the context of each patient and should be trended. However, in the bedside PEWS validation studies, diastolic blood pressure was not found to be statistically significant as a critical indicator to better differentiate sick from well patients. So it is not part of the bedside PEWS score, and only the systolic blood pressure is. Ultimately, both systolic and diastolic blood pressure are important, and if your diastolic blood pressure is too high or too low, it should also be highlighted to your team and investigated. For blood pressure in general, we acknowledge that at times the blood pressure can be challenging to acquire for a patient, as it's not a comfortable test for all patients, and it is difficult to sometimes get a reading when the patient is moving around or crying. Blood pressure is still very important, hence, it is one of the vital signs, and it helps us understand what's going on for a patient in terms of their trajectory and clinical issues. Therefore, it is vitally important to get blood pressure, and we encourage all practitioners to get scores as possible. You can ask if you're having difficulty acquiring blood pressure to any of the clinical nurse educators or to your charge nurses to help better understand how to some tips or tricks on how to get blood pressure readings, and always make sure that the blood pressure cuff is the right one for the patient. This can also be reviewed by educators if you're unsure. Some patients, it's not possible for us to get all seven indicators. A bedside Pew score can still be completed if an indicator is not scored, but the healthcare provider will have to recognize the score is missing that indicator and needs to still critically think around the decisions with this missing information in mind. The practitioner should document the score with a plus sign to indicate that it's a partial score. There should also be a brief reason why the bedside PEWS score was not completed in the assessment or in the notes section. Some examples would be patient is crying, patient is sleeping, blood pressure could not be taken due to concern for increased agitation of the patient. The plus sign indicates that most likely the score will be higher than that is calculated. For all practitioners that order, so all physicians, physician assistants, or other people with ordering privileges in our hospital, all ordered vital signs should now read as per bedside pews and written this way in all standard order forms. As you can see here, I've put a picture of the standard pediatric admission or transfer order sheet. Beside the vital signs, there should be written as per bedside pews. The standard order forms could not all be changed or revised prior to the launch of Bedside Pews, but the plan is with time, as these forms are updated, we will be adding this into the standard order forms in a retrospective manner, and any new projects will need to include this moving forward. How often do you need to complete a bedside pew score? Well, the bedside pew score is calculated every time you complete a patient assessment. The frequency really depends on the score match care recommendations of the patient and the clinical judgment of of the healthcare team. The frequency of assessment will vary between patients. There may be patients where it's appropriate to do less frequent vital signs. For example, a patient who's admitted for um, mental health illness, it may be decided by the healthcare team that vital signs don't need to completed over the night. That doesn't mean, however, that if a clinician goes in the room and they're worried that they should not do vital signs, they can always add them back in. But it can be a decision by the healthcare team that for certain circumstances, the vital sign acquisition and bedside pew score calculation would be less frequent than every 4 hours, which is otherwise considered the baseline vital signs. This decision should be made with the most responsible healthcare provider, most responsible physician, as well as the team. Patients who are acute with higher scores may have reason to have increased vital sign acquisition independent of the bedside pews score match care recommendations. Ultimately, you can always do more vital signs than recommended, and you can score a patient anytime you would like. The vital sign frequency of bedside pews is minimum of Q4 hours for acute patients, unless otherwise determined by the most responsible physician with team, as I gave an example in the previous slide of doing less frequent. In other circumstances, it may be that you might need to do more frequent vital signs and bedside pew scores. An example of this would be a patient with diabetic ketoacidosis, where there's concerning physiology and reasons to monitor more closely. For example, the risk of cerebral edema in these patients. This is why, for diabetic ketoacidosis, neurovital signs are often ordered Q1 hour at the start of their care and spaced out as the risk decreases when the patient gets better with the therapy. The team will decide when to de-escalate the frequency of scoring based on trajectory and also the bedside PEWS score number trends. The recommended bedside PEW vital sign frequency are always a minimum, as I have noted. Vital signs should always be done whenever people are worried about a patient, and a practitioner should never wait for the recommended bedside PEWS time interval to lapse before completing another set of vital signs if they're worried about a patient. In the same vein, you don't need to do full vital signs if you are worried acutely about a patient. For example, if the patient is not making any respiratory effort, you should not wait and calculate a bedside Pew score. You should call a code blue, intervene, and then we can figure out the vital signs later, as at that point, the exact bedside Pew score does not matter. Ultimately, bedside views helps predict trajectory, but doesn't tell you what to do in the moment of patient worsening acutely. If you're already in a peri-arrest or arrest situation, the value of bedside views is actually meaningless at that time. You should not stop to calculate a score. You should start interventions to help the patient and call for help. For other patients who are chronic patients, these patients may have a stably elevated bedside PEWS score. What should we do in these cases? So, if the score is elevated and the patient otherwise looks well, the team can choose to consider this elevated score to be a baseline score. The team can therefore make this score their routine vital signs for the patient, for example, every 4 hours or another frequency as determined by the team, and have a plan to change back the score care recommendations if the score changes by a decided upon value for the team, or using clinical judgment if there's any time where you're concerned about a patient and need to escalate the vital signs or call for help. An example of this would be a tracheostomy and ventilated patient who has a higher respiratory rate than would be typical for age due to chronic lung disease. The baseline PEWS score for any patient who has tracheostomy and ventilation would always be 4. With the increased respiratory rate for age, the patient's bedside PEWS score would therefore be even higher than 4. So, for example, we could say that the score is 5. For this patient, then the team could write in the orders baseline bedside PEWS is 5. Please use routine bedside PEWS vital signs for this patient, Q4 hours, bedside PEWS scores, and vital signs. If the score or the bedside PEWS score increases to the next score category, please change to the care recommendations as for the new value in bedside PEWS. For this patient, this would then be going to the new score category of 7 or 8, and therefore 7 to 8, and this would increase the vital sign frequency and also make new recommendations. The customization of bedside PEWS and the decision for this must be made with the most responsible physician, ordered in the chart, and discussed with the team. Who can document on the flow sheet? The bedside PEWS documentation record is a bedside tool for all frontline care healthcare providers. It is important that all interdisciplinary staff working in the inpatient units and child health be familiar with this flow sheet. That's why these modules are for everyone. The entire healthcare team can benefit from the strength of bedside PEWS. It can help us critically review how the patient's doing, trend the scores to assess for deterioration, and provide for clear communication with the healthcare team. For example, we have prepared some documentation for healthcare aides and unit clerks who often document weights. And physicians can also chart on bedside PEWS when they do a medical review in the bottom section where it says medical review. These are just a few examples, but we encourage all healthcare practitioners to be able to participate in the documentation on the bedside PEWS form. And on the back, where it says healthcare provider, they should just write their name and also their signature and initials just to make sure everyone knows who's documenting on there if you do choose to do so. What if your patient has the wrong flow sheet? So, if a healthcare provider notices that the bedside PEWS record is the wrong one for the age, they should they should immediately notify the team or charge nurse and update the previous nurse caring for the patient just so they're aware. And they should introduce the correct age match score record immediately. Documentation on the incorrect flow sheet will mean the score is not valid because they're only validated for the specific age groups. We should also just take into consideration birthdays and other age transitions, especially in the underage one age group where the form changes more frequently. What happens if a vital sign lands between two colors when you're documenting? The number would be scored for the higher score value. So, for example, in here, the score for the respiratory rate is between the orange and the purple red category. Therefore, therefore you would score this patient as in the red purple category, and this score would be a 4. This ensures that the patient's reassessment occurs in a shorter time period and is conservative on purpose because we're trying to catch all patients who are at risk of deterioration. Which record do I use for a premature infant? For bedside PEWS, you should always be using the flow sheet that correlates to the chronological age of the patient. You do not need to use a corrected age. How do I document frequent vital signs? So there are some patients where, for a period of time, we may need to increase the frequency of vital signs acquisitions. This is shown in the figure here, where the hours are actually just crossed out, and you can write the actual times that correspond to when you're providing your vital signs and bedside PEWS numbers. You should chart the time at the top of the flow sheet. If you run out of room, you can start a new flow sheet and continue to chart the time at the top and clearly date both of the sheets with the same date. For most patients, if this needs to occur, this will be a brief period of time, and generally you're able to get back on track for the remainder of the hours and the 24-hour period for each sheet. For example, this may be for an infusion of a medication that requires more frequent vital signs. If the patient does need ongoing vital signs every 5 minutes, this would be very concerning and potential need to review if the patient needs a higher level of care and frequent reassessments of how the patient is doing. Please note, rapid response teams, Medical 25, and Code Blue are going to be reviewed specifically in Module 5, and I'm not detailing them here. The only exception for double charting for all patients is the blood transfusion record. For the blood transfusion records, we still need to document on the blood transfusion record due to the policies from the Canadian Blood Services, i.e., if we don't chart on the Canadian Blood Services sheet, we won't be able to give our patients blood products. Vitals for the blood transfusions should be recorded on this blood transfusion record, and they should also be documented on the bedside PEWS form as an intervention where you say C scoring tool and blood is provided, or albumin or whatever blood product you're giving. Vital signs will also need to be recorded on the bedside PEWS form to provide the bedside PEWS score. This is what the cumulative blood product looks like for those who are not familiar with it, where the vital signs would be recorded with the frequency as per the policy for providing blood products. How it would look on bedside PEWS would be to just chart the baseline vital signs score, your reassessment at 15 minutes score, your reassessment at 1 hour and score, 2 hours and score, and 3 hours and score, and then 1 hour post infusion. This is generally how the policy is for blood product transfusions, and therefore it's expected that it's written in both places. Please note, it takes less than 30 seconds to calculate a bedside PEWS score with experience, so the goal would not be to add more work. And we do recognize that double charting does pose some challenges and risk. This will be much less double charting than is occurring currently in our hospital, and the purpose of this is only for the blood products. I'll now review other forms that are changing in our hospital and amalgamated into the bedside PEWS form. Firstly, cardiorespiratory event record will no longer be used in our hospital and will be replaced on the bedside PEWS form. The bedside PEWS form will give more information and allow for better trending for cardiorespiratory monitoring. And we are requiring that narrative in the notes section or an IPN be used to describe the event. The interventions can also be written in the intervention box. When reviewing this form, it was noted by the bedside PEWS team that it did not contain all the information that would be helpful for a patient. And in fact, when we chart on the bedside PEWS form, you actually get much more clinically relevant information. How this is done. So this is an example here of charting for a cardiorespiratory event. As you can see, this is specifically writing an actual event that occurred. In this case, the score is 16 because the patient held their breath. So at that moment, their respiratory rate was 0 and they did desaturate. Cardiorespiratory events, as we know, can sometimes come in clusters and can be rapid. So it may be that a nurse will document after a cluster of events and just chart the final, but they should document the pattern and an explanation of what occurred in the note section so we can have a better understanding of what's happening for the patient. The healthcare practitioner should write a star in the box beside the bedside PEWS to indicate that this was a cardiorespiratory event. It can also be written in the assessment box that this was a CR event. The interventions can also be charted briefly in the interventions box. For example, CRM, cardiorespiratory event monitoring and interventions can include self-resolved, suctioning required, stimulation, repositioning, blow by oxygen, or bag valve mask. Other important forms, so the neurological record and seizure record. The neurological record is also consolidated into the bedside PEWS form, and there's space for all the neurological component, including the GCS and tone and all the other important clinical findings on this form in the assessment component on the back of the bedside PEWS form. Therefore, this record will no longer be part of the chart. The seizure record remains as there's no vital signs on this form, and this record will help us record the semiology, which is the clinical features of the seizure. Vital signs should still be included into the bedside PEWS score, and an assessment box can say seizure and C scoring tool, which means C scoring tool or SST, sorry, which may be put in the assessment box to refer to the seizure record. Bronchiolitis and asthma care maps will remain currently in our clinical practice and use. We do ask that vital signs be recorded specifically on the bedside PEWS form and then should state C scoring tool SST in the assessments box. They can also write any other interventions. For example, L-epinephrine was provided. The future state will be to hopefully incorporate the bronchiolitis scores into the bedside PEWS form, but at this time, we will still use the bronchiolitis clinical scoring sheet to provide the score for bronchiolitis. There are stickers that are represented here as this bright yellow vitals as per bedside PEWS, which are printed in on all the wards and then can be placed just our on any other tool that we're still using to indicate that the vital signs are written elsewhere. This is just a picture of the asthma clinical scoring sheet, and the same thing will occur in regards to putting on the vital signs as per bedside PEWS, but the PRAM score will still be, sorry, on this one, we're not yet using PRAM score, but the future state will be using PRAM scores in our hospital as well, but this would be the asthma clinical scoring sheet that we currently have. As I mentioned, PRAM scores will be coming eventually, and the new asthma forms coming soon to our inpatient units will also have bedside PEWS incorporated. The pediatric pain flow sheet, however, will remain also in use. This is because it's actually our medication administration record for opioid infusions. We have requested that vitals, however, be on the bedside PEWS form. So again, not double charting. The only thing that would be charted on here is the opioid infusion, and the sticker would go as I've put on the form here, that vital signs will be as per bedside PEWS, and should write C scoring tool corresponding with the time that you're documenting the infusion on the infusion sheet. The same thing will occur for the pediatric continuous epidural form. Vitals, again, will be using the sticker to say vitals as per bedside PEWS. This is so that the one source of truth for all vital signs will remain the bedside PEWS form, but these are medication administration records as well. So we're still keeping these forms otherwise. As noted and emphasized in earlier modules, the vital signs record will no longer be part of our inpatient clinical records. If you run out of space in the notes section on our form, you can use an IPN, integrated progress note, dated the same day. This will provide more information and allow for the trending and graphical representation of the vital signs on the bedside PEWS forms. That being said, you may still see the vital sign records forms used in other areas if they're moving from that area into the inpatient unit. This is only specifically for outpatient units such as the pediatric day unit, pediatric day surgery, or in the post anesthetic care unit, where they may use the vital sign record until they are now transitioned to an inpatient. Note, you cannot then continue on using that vital sign record for that patient because using the vital sign record, you will lose all the benefits of bedside PEWS. We recognize this is one of the biggest changes, and we really thank you all for your collaboration and understanding as we improve this safety for all of our patients. So the other forms that we're replacing are numerous, and I haven't put the example of them all here. However, our team will be removing all of the forms from the units on the day of bedside PEWS implementation for those units, and now all of the documentation will be as per bedside PEWS. Few other examples would be the clinical flow sheet, which is being replaced, and nursing activity flow sheet from CK5. If you're uncertain about any other form, please discuss this with an educator, one of the bedside PEWS champions, or myself. Ultimately, we want to simplify the charting and have people able to find all the information that's important for a patient. We are also aiming to avoid any double charting of vital signs, except for the noted exception of the blood product administration. Moving on to a few other scenarios. What if the family is refusing a patient assessment? This may happen when a patient is sleeping or for other reasons that a parent may not want their child disturbed at that moment. We recommend that you listen to the parents and hear out their rationale. To please explain the purpose of Bedside PEWS program and how this will help assess the patient's need and the plan of care. Using their clinical judgment as a team, you can decide if not assessing the patient at that time is appropriate based on the patient's condition and current clinical status. If you are not able to get all of the critical indicators, please mark the score again with the plus as noted before and write a note in the note section. In this case, it could be indicated that family is reviewing the patient assessment and further reasoning for that. For palliative care patients, the bedside PEWS flow sheet can still be used and to document all the vital signs. We will not be using a different form for palliative care patients. However, the score match care recommendations should be decided upon as to what is relevant for the patient, and ensure to include the most responsible physician and palliative care into the decision making. It can be important to trend clinical features in a palliative care patient. However, it would be important that things like code blues do not get called if they don't fit with the goals of care for the patient. The advanced care planning or ACP status will still be of utmost importance, and consideration of the bedside PEWS scores do not override this type of care plan. As highlighted again, the bedside PEWS is only recommendations and not mandatory actions. Another important feature that was of concern when we're changing is the patients with frequent weight assessments and fluid balances and losing the daily trends. We are now implementing an interim strategy while we work on updating other processes and forms in our hospital. Weights will be recorded daily on the bedside PEWS form, and the changes to the weight will also be indicated at the top. There's a space to write the date, the weight, and the date that it's acquired, and the previous weight and the date acquired. For patients who have weight as a main clinical issue or require more specific following of their weight, a nutrition tracking sheet will be used as an interim method. This will be the same thing for if the fluid balance is required to be closely monitored, and it's also on the nutrition tracking sheet. Intake and output sheets are not changing otherwise at this time. However, we are working on a new intake and output sheet. This is what the form will look like. And for specific patients that require the anthropometric tracking can be used with the date and the weight would be written as well as if the length, head circumference are being followed more specifically and fluid balance. This can be ordered specifically and put on the chart for patients that require. However, it will not be part of the permanent record at this time. All the information that would be put on the nutrition tracking sheet should be written elsewhere on the permanent record, for example, the bedside PEWS form or the fluid balance record. This will be interim just to help the clinical team better trend things while we're working on updating a few other processes for our hospital. Firstly, we're working on a malnutrition screening package and program, which would ultimately have a form that would remain part of their clinical record. This nutrition tracking sheet is one of the draft versions of that at this time. And I sincerely thank Dr. Jeanette Hayward and the team for providing this to us for the interim form. Similarly, we are working on a new intake and output sheet for the whole hospital that will also be unified, but at this time we're not changing it. But if a patient needs to have their fluid balance more closely tracked, for example, a patient on dialysis or with nephrotic syndrome or something else concerning, can also be tracked daily. Finally, it is important and necessary to emphasize that there's no physician that can order to discontinue bedside PEWS. This is our new system for all patients at all times and should be the system used moving forward. In the last part of this module, I'll just briefly go through a few other considerations for our patients and a few last reminders. So firstly, clipboards will be kept at the bedside and we'll continue to have our bedside PEWS forms, which will replace where we had our vital signs in before. At this time, we're going to keep 2 prior days on the clipboard and the current day. This will help facilitate trending for physicians and for the healthcare team when they're trying to find the patient information. This process will be reviewed in an ongoing manner and determined if we need to make changes or not to this process in the future. Finally, we are encouraging that everybody embed bedside PEWS into their daily communication, including things like nurse to nurse handover, talking about bedside PEWS trends, doing progress notes, SBAR communication, patient care rounds during the day, and anytime the care it needs to be escalated to talk about bedside PEWS trends. We will discuss this further in Module 5. Of note, we also encourage anybody who's starting a shift to go in and assess the patient and do their own initial bedside PEWS calculation just to get a better sense of what's going on with the patient, and it can help you understand the trajectory throughout your shift when you're on. I'd now like to really thank and emphasize that we have a group of Bedside PEWS champion, which we are now calling our Bedside PEWS crew. These champions will have t-shirts that look exactly like the picture that's pictured here. And they are nurses or other healthcare clinicians who have had extra training on bedside PEWS. They've come to numerous other sessions and done practice scenarios, and they will all be working through the first 2 weeks when we are launching bedside PEWS. We've arranged to have champions on almost all shifts on all the units when we roll this out. They are the people that you can ask your questions to right away, and they should have the answers. If they don't, then they can go to the educators and escalate beyond there. Please don't hesitate to ask any person wearing this t-shirt any question anytime when Bedside Pews is rolling out. We've also specifically asked them to be checking in with all bedside clinicians to help support this transition to this important new tool. As mentioned numerous times, our ultimate goal is to have a culture of safety, which will be our bedrock in the hospital, and to have increased, enhanced team communication. Bedside Pew scores will ultimately also be written on the central whiteboards. This will be coming in a future state. It will be discussed in daily huddles and ultimately improve team communication about the level of acuity of patients on the units, help match resources, including human resources, to units with higher acuity, and overall improve our situational awareness of how the patients are doing. We would also like to really emphasize that staff will be catching things early, doing an excellent job in identifying patients at risk and helping us get a clear example. We would like for people to highlight if there's good catches, recognizing um, what excellent staff we have here. So please celebrate the successes. And if you do have any great stories to share, please pass them along, as we would love to keep all of our staff updated with how this project is working. So this is the end of Module 4. In summary, Bedside Pews is a large systems change and impacts numerous other forms. We reviewed these throughout this module. We also reviewed numerous other challenges and special considerations. We also reviewed that if something new is encountered, that it should be flagged, and these issues brought to the Bedside Pews champion, nurse educators, clinical nurse specialists, or myself as the project lead. What I mean by this is that we've worked really hard to try to anticipate any special considerations or challenges, but there's going to be something we didn't think of. So please bring it to us as soon as possible so we can help figure out and troubleshoot what we should do. The next and final module will review how to escalate care using bedside pews as embedded in our escalation of care process. Thank you so much for your attention during this module.